Perfect. Hello, everyone. Welcome to this session of the Safer Birth Now virtual conference. My name is Theodora James, and I'll be moderating today's session, Advocacy Without Anxiety. And I see we have a few people. If you don't mind, if you could put where you're from in the chat, and we'll get started shortly. We have New York in the house. Hi, Don. Georgia. South Carolina, Denver, Kern County, Philly, right?
Could have had lunch, y'all. We could have had lunch.
Dallas, Florida, Ohio. Wow. Chicago, the Midwest is in the house. Have California, Oregon. I love it. I love it.
She's a doula.
We have doulas, right? Childbirth educators. A lot of doulas here.
Any nurses in the house? Happy Nurses Week. It's our week.
Oh, it is. Happy Nurses Week. I totally forgot. Look, this week has been
the disrespect.
It's my week. I love it.
Don't ask us for no all-record diagnosis there. Y'all forget out.
Okay, so we got 250. Oh, wow.
There's appreciation.
So we will give a few more minutes. We had 250 individuals registered for this, so just giving people time to join. But just to let you know, if you all have any questions, we'll be able to answer that after the presentation. But if you could put it in the chat while we're going along, that would be helpful. Certified breastfeeding specialist.
Yes.
Marie, are you able to put the QR code back up so that they can scan it for them?
It's on a rotation. Sorry.
Oh, got it. Okay. So it'll come back around. Who asked that? Kamaya. Health workers. There it is, Kamaya.
Everybody. So glad to have you.
You're welcome. For those of you who just entered, if you don't mind putting where you are from in the chat, and we will get started shortly. Washington State, another South Carolina. Pennsylvania, Kentucky is in the house, Connecticut, California, Indiana, the Virgin Islands. I love it. I love it.
project right
Right. We have Portland in the house, Kern County,
Florida,
more, right, Florida.
Paducah. Okay.
All righty, let's get started. Thank you all for joining the session. Once again, my name is Theodora James, and I'm going to be the moderators for today's session, Advocacy Without Anxiety, Trauma-Informed Communication. So this is a Safer Births conference, and the Safer Births Now conference brings together clinicians, researchers, and innovators, parents, and their loved ones to have advocates from around the country with a shared goal of improving outcomes for Black mamas and newborns. So we're excited to have you join the session. So I will be introducing Ms. Rachel Dumas. And let me tell you, and I had to pause for a second because this woman, oh my gosh, when I say incredible, I met her a month ago. And when I say she is just so humble when it comes to all of her accomplishments. So I want to give you your flowers now because I don't think I told you that, but I am so proud of you. But she's a registered nurse, an advocate, and the founder of HERD, a platform focused on transforming the way patients communicate and escalate concerns within healthcare. Through her work, she helps patients and caregivers learn how to advocate for themselves with clarity and with confidence without feeling anxious, overwhelmed, or dismissed. So, in addition to her accomplishments, Miss Rachel holds a master's in science of nursing informatics and is currently pursuing her doctorate in nursing practice and nursing informatics, in which she did not tell me. Look, I had to go on her LinkedIn to find this. So that's why I'm saying she's very humble when it comes to her accomplishments. So her work is uniquely informed by both clinical expertise and lived experience. After navigating pregnancy loss and experiencing firsthand challenges of the healthcare system that can sometimes overlook patients' voices, she became deeply passionate about patient advocacy and trauma-informed communication. She's nationally recognized speaker and maternal health advocate who has shared her experience with audiences across the country, focused on patient safety, health equity, and navigating healthcare systems as a whole. At the center of all of her work is a powerful mission to ensure that a patient feels heard and they go in to ensure that they have to advocate for themselves. So I would like to introduce Miss Dumas.
Thank you so much for that introduction. I was like, who is she talking about? But just kidding. But I'm so happy to be here. Thank you, Marie, for just having me here. I'm humbled to be a part of this. And thank you all for showing up and spending your Wednesday evening with us. I am just honored to be in you guys' presence and your expertise and your experience. And this is an interactive presentation. So feel free to stop me, put your questions in the chat, your reactions. Let's enjoy this Wednesday. So let's get into it without further ado. So this is Advocacy Without Anxiety, Trauma-Informed Communication in Maternal Care. And yes, I am Rachel Dumas. I am a registered nurse. I am a maternal health advocate, and I am a tech founder as well. But for this presentation, like today, we are going to explore how trauma impacts communication during maternal health experiences. And we'll discuss what dismissal can look like in real time and how communication breakdowns contribute to unsafe outcomes and practical strategies that patients, caregivers, doulas, and other healthcare teams can use to improve advocacy while reducing anxiety. And most importantly, this workshop is about collaboration and not opposition. So let's work together. And then the reality of patient experience right now. So one of the biggest challenges in healthcare is that patients are expected to advocate for themselves in a system that they do not fully understand often. And the honest to God truth is we don't know what we don't know. And even as a registered nurse, I was in trauma before I got pregnant. When I got pregnant, went to maternal health, I knew nothing about birthing babies at all. So I was completely new to it, and I didn't know what I didn't know, and it cost me, almost my life at some points. And other patients feel the same way in different specialties. So, but they're still expected to navigate this while they're afraid or overwhelmed or in pain or emotionally dysregulated. And many patients feel unheard during clinical encounters, and communication failures remain one of the leading contributors to serious medical errors. 87% of patients state that they are not being heard in the healthcare system and in during their healthcare encounters. And it's not just a patient issue, it's a systems issue. And maternal care becomes even more vulnerable because emotions and trauma and urgency are often heightened during these scenarios. So the reality of maternal care is that many pregnant patients do not enter care emotionally neutral, right? Some have experiences with pregnancy loss, like myself. Some have experienced medical racism or dismissal. Some are carrying fear from previous births and traumas within the healthcare experiences that they already had. So when communication breaks down during pregnancy or labor, the impact can be very profound, and that trauma-informed care asks us to understand that emotional distress and physical symptoms are often connected. And when patients repeatedly say something feels wrong, we should listen to them. So, trauma-informed care and trauma-informed communication focuses on that safety and that trust and that collaboration and that clarity. And one of the big misconceptions is that advocacy means conflict. But advocacy can actually sound like, can you help me understand this? I'm concerned because this feels different. Can we document this concern? And these phrases should create a dialogue instead of an escalation, right? The goal is not to make the patient feel smaller or quieter. The goal is to create communication that keeps everyone regulated enough to think clearly and to work together so we can achieve the best outcome for the patient. So, all these are a bunch of words until we're in the hospital or in the ER, in the doctor's office, in the maternal fetal medicine office, or at home and we're pregnant and we're the patient. Or if you've been a patient, if we're the interdisciplinary team member. So, like I said, this is interactive. So I want you to pull out your phones and we're going to go through a patient scenario and we're going to vote on what should have happened throughout this woman's scenario. This is one woman's story, and we're going to go through her pregnancy journey. And I'm going to present you with a scenario, and then you're going to vote on what should have happened. So today, if you're usually in the patient seat, you're going to put on your scrubs and or you can act as a family member. But take out your phones and be prepared to scan the QR code or use the text code so you can vote. And it'll show the results in real time. So everybody ready? I can hear the excitement. So it is October 2018. This woman, she has a history of asthma. She had a tonsillectomy at age 8. She's 28 years old, pretty young. She has a familial history of pregnancy loss, which she does not know about until later in her journey. So her mom had a stillbirth and a miscarriage, and her maternal aunt had 7 full-term losses, stillbirths, all boys. She later went on to have 2 girls. Um, she is pregnant. She takes a pregnancy test at home. She goes into the OB's office. They do a vaginal ultrasound, and she is told you are having a miscarriage. This is her first pregnancy, and it ends in a miscarriage. So, for this patient, which trauma-informed advocacy approach could have improved communication and patient support during this time? Should we immediately reassure her, the patient, that miscarriages are common and encourage her to try again later? Should we provide a diagnosis quickly, discharge the patient, and recommend follow-up if symptoms get worse? Should we acknowledge the emotional impact of the experience, discuss warning signs, invite questions? Should we avoid discussing the patient's family history unless miscarriages occur in the future? What are we thinking? Acknowledge the emotional impact. And I put that specifically on there because a lot of times, one, when it's an early miscarriage, oftentimes it happens at home. But even when it happens in the healthcare setting, a lot of times these moms don't get those emotional or mental health resources. And definitely the family doesn't, right? So a lot of time you hear, oh, it's only one, you can go on and try again without even acknowledging that in this very moment, this was hard enough as it was to get this baby. So it's very, very important to assess those needs, and see what the patient may need as far as those resources, and just to check in, right? A loss is a loss. I don't care if it's one or five, a loss is a loss. But also invite questions, like be open. Thank you for this. So let's skip to 2020, the dreaded 2020. Anybody else have PTSD during 2020? When I see the numbers together, it just does a little something to me. But let's go to August 2020. She's at work. She has pregnancy-like symptoms, sore nipples, nauseous. She takes a pregnancy test and it's positive. So instead of going to the OB's office this time, she actually goes to the ER, and she is told you are having twins. She's also bleeding, so she gets a vaginal ultrasound, and the doctor finds a subchorionic hemorrhage. So when the baby's, for those who don't know, when the baby's implant into the uterus, sometimes it could leave a sac of blood. Most times it is reabsorbed by the body. You're going to have a healthy pregnancy and everything's fine, but sometimes it is not that simple and it could be detrimental to a pregnancy. So she was told to follow up with her OB. By the time she gets to her OBGYN, she has excruciating pain, 10 out of 10. She is nauseous, she is vomiting, she is cramping, the bleeding is worse, and she is sent home multiple times despite of these symptoms. She goes to the ER 8 times and is sent home and dismissed multiple times, stating everything looks fine and the babies are fine. But at 13 weeks and 3 days, she loses baby A. This is a twin pregnancy, so she still has another baby. Here we are, October 2020. She had the ultrasound to confirm the loss of one of her babies. She's still pregnant, but after the loss of the baby, she felt great. All of the symptoms resolved. But one morning, the morning of her gender reveal, she goes to the bathroom after waking up wet, assuming that she urinated on herself. She actually goes to the bathroom to clean herself off, and a few hours later, she goes to the bathroom because she feels something in her vagina, and the baby falls out in the toilet. She seeks emergency care. She goes to the ER, the same one she went to the entire pregnancy, attempting to get treatment for something being wrong. And she tells the doctor, hey, I was 15 weeks and 3 days today, and I went to the bathroom and the baby fell out. And the doctor asks her, how did you even know that you were pregnant? Shocked. She said, well, it was 15 weeks and 3 days. I've been to this hospital many times. You should see the records on there. Like, it will prove I'm a patient here. She asks, do you want to see the baby in the toilet? And the doctor said yes before she would treat her. And that's how she was treated. So, what can we do for this patient? So, which communication and advocacy approach could have most improved this patient experience? Maybe focusing on reassuring ultrasound findings to reduce the patient's anxiety and encourage routine follow-up. Should we recognize the persistence of symptoms despite of reassuring tests and validating the patient's concerns? Should we limit discussions about possible complications the until definitive diagnostic findings appear, or should we encourage the patient to wait for symptom progression before seeking additional emergency evaluation? So one thing I love to tell my moms and their family is like, and I'm a registered nurse, like I am not perfect and we're literally practicing medicine. And while we may be the experts in our specialties and in our field, at the end of the day, you're the expert of your body. And everybody does not present the same. Unfortunately, I do not present like textbook symptoms when I'm sick. Um, and one of the things that I pray for often, if I ever get sick again, I hope it's just like very textbook so they can easily identify what it is so I can easily get treatment, but that's just not the case. So I learned when I worked in the ICU at Grady, if a patient tell you something wrong, something is wrong. Something's wrong. So do the further investigation and trust your patients. They know their bodies. They do. And they may not be able to name it, but they can identify that something is wrong, and it is our duties to listen. So here we are. losses number 4 and 5. So it's December 2020. After that hospital admission where she lost her second baby, she followed up with the OB and she was diagnosed with cervical insufficiency. So her cervix is too weak to carry a baby full term. So around the end of the first trimester, beginning the second, when the baby is heavy enough to sit on the cervix, it begins to open because of the weight of the baby. And the cervix being too weak to hold it closed until 38, 39, 40 weeks. So the treatment is a cerclage. She was told that she has to make it to 13 weeks. She was not told about another option, which is a transabdominal cerclage, which you can get outside of pregnancy. She was only told about a transvaginal cerclage, which is typically placed at 13 weeks of pregnancy. So the issue is she had multiple early losses as well. It wasn't just the later losses, which would be associated with the cervical insufficiency. So, despite of the patient notifying her doctor, she was not referred to any specialist, such as a maternal fetal medicine doctor or a reproductive endocrinologist or a reproductive geneticist, until she went to a friend's OB's office, who was a maternal health nurse practitioner. They put her on a medication called progesterone, which research shows it can strengthen the cervix. Some doctors feel like it works. Others feel like it doesn't. But she was told to take that as soon as she got the first pregnancy test to help her make it to 13 weeks. She also went to work. She worked in a healthcare facility. And her manager said, hey, you should ask your OB for a referral to a reproductive endocrinologist and a reproductive geneticist to see if there is a genetic component to the losses. And they can also test your husband's sperm to see if that could be a cause of the losses. There's blood work that you can do, like a vitamin D panel or a vitamin panel to see if there are vitamin D deficiencies, which is commonly associated with miscarriage or certain autoimmune diseases could be. She goes to the OB. OB happily writes a referral for these providers. She goes to the geneticist along with her husband. There's no genetic component to the loss per the testing. And then she goes to a reproductive endocrinologist who says, there's no autoimmune disease that you have that's associated with it. The vitamin D is fine. We're going to do further procedures to look at the shape of the uterus, maybe see if there is underlying inflammation that could be causing the losses. Make sure we check your fibroids because she did have small fibroids that could be associated with miscarriage, depending on where they are and how big. But on the day of the procedure, she finds out that she's pregnant. And she continues to see the reproductive endocrinologist for the first trimester. She also starts the progesterone suppository, the vaginal suppository, to hopefully prevent miscarriage at least until she can get the cerclage, the transvaginal cerclage at 13 weeks. And she makes it to 13 weeks. She graduates from the reproductive endocrinologist to the maternal fetal medicine doctor, and she gets the cerclage. Once the procedure was done, she was told to come back in 7 weeks. However, she had 5 losses. This was her sixth pregnancy. So she begged the maternal fetal medicine doctor to see her sooner. However, the doctor refused, stating, hey, if this cerclage fails, which I've never seen it happen, you would have excruciating pain and you would have bleeding. It would be fireworks. You would know. And the patient, who is tired and just stopped advocating because she's trusting her doctor, she said, okay. So here we are, 7 weeks later, and she's in the maternal fetal medicine office, and she is getting her ultrasound. The baby is healthy and bouncing around. However, mid-ultrasound, the tech stops, walks out, and says, the provider will be in shortly. The patient knows something is wrong. The maternal fetal medicine doctor walks in and says, hey, your cerclage failed. The patient was shocked. There was no symptoms at all. Matter of fact, she felt great and the baby was healthy. She asked the doctor, hey, can I be on bed rest? We're 20 weeks. This is the longest I've been pregnant. I could just wait 2 more weeks to deliver or attempt to stay pregnant 2 more weeks because this hospital can hold a micro preemie and I could give birth at 2 weeks. Or can we revise the cerclage? Can we put a cerclage higher than the one that you gave? She said, no, those are not standard of care. You can go and deliver. I'll call the triage. And the patient said, no, I'm going to fight for this pregnancy. This is the longest I've been pregnant. So she does her research and she found that in the instance of a failed transvaginal cerclage, which is what happened to her, that doctors have put in a transabdominal cerclage above that cerclage. The issue is she was 20 weeks pregnant and she had to find a doctor who would do that. So she called her colleagues and her friends and family, and they found a doctor in Dallas, Texas, Dr. Falwell at Texas Health. He calls her after she called the office and said, if you want to fight for this pregnancy, I'm willing to fight with you. He asked her to fly. So with a baby falling out of her vagina, she flies to Dallas, Texas, and she makes it. And the red carpet is rolled out as Dr. Falwell is known for doing high-risk surgeries of such and have saved many babies over his career. And she takes a medicine to try and prevent contractions, and she essentially rolls back to the operating room. That 3 hour surgery took 8 hours as the baby had dropped even further because, as you can imagine, the altitude to being on a plane and just from being vertical. But when she woke up, she had a bunch of healthcare providers cheering her on as she was still pregnant and the surgery was successful. However, when the anesthesia wore off, the contractions set in and she was in labor for 30 hours. And despite of all the tocolytics, which is a medicine to prevent contraction or to stop them, she continued to have contractions. And at hour 30, she stood up to use the bathroom and her water broke. She had to go back to the operating room, get both of the cerclages removed, and she delivered a baby at a little over 21 weeks. And the doctor said if that was to happen, he would personally fly her back out, put in a transabdominal cerclage in outside of pregnancy, and that she would go on to have a baby. And crazy enough, she believed him. So the baby was buried in the hospital in Dallas, Texas, and she sets an appointment for talk therapy. She was never asked if she needed any resources for her mental health, emotional health. What can we do for this patient? Which trauma-informed and patient-centered response would have been the best support for this patient? Should we reassure the patient that no symptoms likely meant everything was stable and she should just maintain follow-ups? So it's it's no news, good news. Should we recognize the patient's repeated pregnancy loss and history and made a clinically and emotionally significant or individualized treatment plan? Should we discourage additional questions or alternative opinions to avoid increasing the patient's anxiety? Should we focus on immediate clinical management after cerclage failure and avoid discussing emotions? Should we ensure the patient understands all available interventions and second opinions for, opportunities? I'm seeing recognizing her repeated loss and making an individualized treatment plan. I'm also seeing ensuring that she understands all available interventions. So is it truly informed care if she was only told about a transvaginal cerclage? Should she have been given the option to get a transabdominal cerclage as the doctor in Dallas, Texas did? Absolutely. So here we are. She sustained a few other losses after that loss in Texas, but true to his word, Dr. Fogwell flew her out to Dallas, Texas. He did a DNC to make sure there was no retained pregnancy after all the losses, gave her some antibiotics just in case there was any underlying inflammation because of all the pregnancy losses, and also put in a transabdominal cerclage. She continues to do hypnotherapy and talk therapy. And May 2022, she achieves a at-home positive pregnancy test. She has had 9 losses. This is baby number 10. She is closely monitored by the reproductive endocrinologist in Atlanta. She then graduates to the maternal fetal medicine doctor 13 weeks later. And at the start of the third trimester, she begins to experience shortness of breath anytime she's vertical, dizziness, headaches. Her oxygen levels were decreasing, so she's referred to a cardiologist. He puts her on a medicine called metoprolol to decrease her heart rate, hoping to improve her oxygen levels. However, it barely worked, and he sent her to the emergency room. During the emergency room experience, she waited over 8 hours with shortness of breath. During the experience, she also saw a pulmonologist who said, "You need oxygen. If your oxygen levels stay low, it can hinder the baby's growth, development, and brain function." Oxygen was ordered. What could we do for this patient? Which trauma-informed approach would have been the best support for this patient? Should we reassure the patient that symptoms can be normal in pregnancy? Should we prioritize symptom escalation and coordinate care and emotional support? Should we encourage her to come to the ER less? Should we only focus on physical symptoms at this time? So this mom had 9 losses at this point. She's pregnant again. She can't breathe. Her wait times in the emergency room are 8 hours plus. She is ordered oxygen, or she is told that if the oxygen is not working or your oxygen levels are staying low, you need to deliver within 10 minutes. Now, this patient lives in Atlanta. I can't even get to my mailbox in 10 minutes on some days. So I don't know how you're going to get not only to the hospital, but in the operating room to get a C-section because she has a transabdominal cerclage. She has to get a C-section. So definitely should have had a better plan. She should have stayed hospitalized. That would have been the best option for her at this point. But definitely escalating those symptoms and not just saying, "Hey, we're going to send you oxygen at home." Well, the patient never received oxygen. She had to deliver at 36 weeks because her oxygen level still was dipping down. But on 12/30/2022, she delivered a 4-pound, 15-ounce baby boy who spent 3 days in the NICU for breathing assistance. As you can imagine, she did get steroid shots leading up to the delivery to help with the maturation of his lungs. But he was in the NICU for a few days for breathing assistance, hypoglycemia, and feeding difficulties, which is the trifecta. If babies can't breathe and they can't eat, so their sugar goes low. But he is healthy now. And as for the mom, if you don't know, this is my personal maternal health journey. I had 9 pregnancy losses before finally having my baby, who is now a pot-bellied 3-year-old toddler who runs this house and pays absolutely no bills at all. Um, but my journey didn't end there. 6 months postpartum, I woke up completely blind. Like it was black. I thought I didn't pay the bill and we had a blackout. And I had stroke symptoms. I had slurred speech and I was falling down the stairs and nauseous. And I went to the ER. And even with a neurology healthcare background and being a registered nurse, a doctor completely dismissed me and refused to do a CT scan. He told me that the CT scanners were down. I had my husband call imaging and they said that is not true. We've done multiple CT scans for strokes. And he said, "Well, you're not getting one today." And he dismissed me saying I had a stomach bug. I immediately went to another emergency room, considering I'm a nurse and I know that strokes are time sensitive as far as treatment. I wanted to make sure I was seen in a timely manner. But I did a CT scan, nothing came back abnormal. I did some MRIs, but for 6 months, I woke up blind at the beginning of the day and it progressed to blurred vision and double vision. And some nights I actually regained my vision. But at 6 months, I did a lumbar puncture and found out I have a rare brain disease in which, for no reason at all, the fluid that's naturally occurring in your brain and your spinal cord called cerebral spinal fluid, there was an overproduction of that. One of my neurologists said, "Hey, it's because you've been pregnant so long, the body is used to accumulating fluid," but others feel like it's just luck of the draw. And I was put on the medicine to decrease the fluid and to normalize the fluid production in my head. But 2 years after that, when I was finishing my master's degree, the medicine just stopped. And I finished my master's on April 30th. May 1st, I was in the hospital. and it led to two brain surgeries 8 months ago. And the only reason I survived that is because I did research because I was finishing my master's and I was in research mode. And I found that GLP-1s like Zepbound or Ozempic actually decreases the pressure in your brain from my rare disease in 12 to 24 hours. And at the 3 month mark, it decreases the risk of mortality. It decreases the need for medicine and more surgical intervention. And that's how I'm here because a year ago, I was planning my funeral. Crazy. So there's definitely a missing infrastructure in the hospital. Right now, when we talk about the need for escalation, there are typically two escalation pathways. One, in the hospital, we do incident reports, and usually the person closest to the patient or spends the most time with the patient, typically the nurse. If there's a safety issue or some event, we put in an incident report in the system and then it's reviewed. Or 2 or 3 days later after discharge, you get a discharge survey, usually press gaining. And that's where you can say, oh, this happened, this happened, this happened. But if you tell me as your nurse that you have chest pain and I say, oh, you just have anxiety, you'll be fine, but then you go on and have a heart attack, who's going to put in that incident report? And who's going to be accountable for that? Right? Am I going to put that in and risk losing my license or whatever the case may be? Are we going to be honest about the situation? So many balls are dropped. There is really no autonomous, at least platform. You can call ombudsman and call in a charge nurse, but there is no autonomous platform in which a patient can escalate harm and tell their side of the story in the healthcare setting. Now, one of the most important parts of trauma-informed care is understanding that advocacy is not always hostility. Like patients may advocate from a place of fear and grief and trauma and previous dismissal. Emotional communication is often labeled as distress or disrespect, but a lot of times it's because of distress. And as healthcare professionals, our ability to remain regulated can completely change the trajectory of that interaction. If they go low, we don't have to go lower. But there are practical advocacy tools, and this slide focuses on preparation. So patients advocate more effectively when they are writing things down, when they're clarifying goals, when they bring support people, they ask follow-up questions. And doulas and caregivers play a really, really, really big role in helping patients stay emotionally grounded during stressful moments. And doulas, the the research is there. If you have a doula on your side, it's better healthcare outcomes, especially maternal health outcomes. And despite of this, with the Medicaid cuts, doulas are not covered in every state. So not only is that a barrier for doula care, despite of the research that we do, but a lot of hospitals still recognize doulas as a guest. When I gave birth, a doula was considered a guest. And because I had a C-section, I could only have one guest. Now, if we being honest, if we had to pick between a doula and my husband, like who's the better option for me? It's gonna be the doula. If we're being honest, it's gonna be the doula. But who am I to tell this man he can't see the birth of his child that we work for? But we know the doula would have been better in this situation, just speaking from a place of logic. Don't tell him I said that. We have a good co-parenting set up right now. So, but I'm just saying it's between us. But anyways, it's sometimes I wonder what are we doing a research for if we're not changing the practices? Like, what is it all for? But that could be a whole nother presentation, and I won't do that. But anyways, but all of these experiences ultimately led me to create this innovation because I saw a gap, and it's called HERD. It stands for Human Enabled AI Reporting and Documentation, and it's an app that I created to help you advocate for yourselves in the hospital. So it'll tell you who to talk to, exactly what to say to make sure you're heard. You can do documentation of symptoms. So it doesn't have to be bad, right? You could create a case and say, when I was in the hospital, doctor told me this, I have to follow up with this doctor. And you can use video or notes or voice or however you want to document is there. And it'll timestamp, and you can even add a hospital or a healthcare facility that you were in to make sure you're keeping track of your healthcare information. there is a new feature that I'm coming out with called a family tree. So if you're on Herd and your mom has it and your aunt have it and your healthcare information in there, y'all, it will create a family tree for you guys. And then you can start seeing what runs in your family. So maybe you don't need to wait till 50 to get a colonoscopy. Maybe you need to get it at 35 because colon cancer ran in your family or whatever the case may be. It also allows caregiver connectivity. So you can add family members or whoever gives you permission on the app, and you can see them maneuver through the hospital, like literally see them maneuver. So if you're in Georgia and we have a family member in Oregon and you can't make it there, you can still be involved in their care. You can escalate harm within 60 seconds in the app and so much more. So I am currently doing beta testing and am working with doulas because it also has a doula feature where they can keep track of all their patients, see who's in the hospital, who's out the hospital, who has a clinic visit coming up, who is high risk and why they're high risk, when they're due, all their vitals, all their birth plans are in there. It's very organized. So the doulas who have been testing it love it. And so have the family members because it's a game changer because we can't always leave work. We can't always be present in person, but we still want to be actively involved in people's care. And people want us to. So if you would like to beta test, go ahead and scan that right there. And that concludes my presentation. I am, again, so grateful to be here. If you have any questions, I would love to answer them.
Thank you, Rachel, for your presentation. And you're getting a lot of hearts, a lot of just
Oh, thank
compliments in
you.
the chat because I know you can't see that. And
Yeah.
the participants are basically thanking you for being very vulnerable within your presentation, in which, of course, we met, but it was actually different to actually go through the different pregnancy losses with you. And
Yeah.
I know just bringing that up can just be just remembering all of that. But thank you for actually taking us through the journey with you because advocacy is so important. It's just so unfortunate, especially for pregnant women. Of course, with me working in this space, you have a lot of moms, as you stated, I was just tired. I was just tired. So when you're tired, you don't have the energy to go back and forth with the healthcare team when they're saying, "Hey, you're fine," and you're literally like, "No." I am crumbling inside. Okay. But thank you so much for being vulnerable. Yes, if you all have any questions, please drop them in the chat and we'll go from there. So while you all are getting your questions together, I actually do have one question. As far as the doctor that did dismiss you, what happened in that case? Did you go back? Did you tell the board? Did you do anything? Because that's one thing I feel as far as advocacy that needs to happen. Because just think how many people that doctor probably dismissed.
Yeah, so I have never seen this woman again, and it is so crazy because like after that, I was like through the maternal fetal medicine office where she still worked, and I never saw her again. It was just so crazy. But I prayed
Really?
to God. I was like, God, I've never been to jail.
No.
But no, I was like, I just don't. It was so fresh. I'm like, I don't know if I can see her now. But the crazy thing is,
Mhm.
like, I didn't sue or anything. What I did is I now work on the board, the Patient Family Advisory Board, and I say,
Mhm.
you know what? A one-time lawsuit, you get a payout. But what is that going to do for all the women and families who came behind me? It's not going to do
Okay.
it. So what I did
Mhm.
was I went on LinkedIn and I added all the C-suite, and I told them my story, and like they set up a meeting the next week. Like it was days later,
Got it.
and
Okay, okay.
yeah,
And
we
one
talked.
thing I have heard, as far as when things like that do happen, have them notate that in your record, just so
Mhm.
that they'll know if anything does happen, you have it in your record that you were dismissed.
Yep, yeah. But I really want to make that big difference, and I am like I'm still like we meet every month, and I've done public speaking with that hospital, and like they love me there, and we really like work on different maternal health issues. Like we renovated the maternal health pathways in the ER at that hospital because
Hmm.
that's a big issue. Like a lot of ERs are not equipped to
Hmm.
handle maternal health emergencies. So yeah.
That's definitely needed because that is so true. Usually, typically they send them to the OBGYN clinic or whatnot. But what if, to your point, is an emergency and they cannot get there? That becomes very problematic.
Mm-hmm. 100%. So yeah, a lot of changes have been made, and I feel like I've made more of a difference that way than doing a lawsuit. So, and I still have not seen her, which is crazy, but
Really,
yeah.
it wasn't meant, but it all shaped for everything of what you're doing now. So that's amazing. Amazing. Like I said, you have so many compliments in the chat. And I guess you were very thorough because I don't believe we have any questions either. But a lot of people are great. And I see that you put your Rachel's contact information is in the chat. You have her LinkedIn because a lot of participants are interested in the app, the Doula
Yeah.
app.
And scan the QR code. And I could get married to send it out too. I'll send the links as well if you want to be a beta tester. Great.
That's awesome. Well, thank you again. This presentation, which is very, very insightful. So yes, so if you all don't have any questions, I would like to say the Safer Births Now virtual conference is made possible through the support of our sponsors and program partners, and we extend our sincere thanks to our title sponsors. Birthing the Magic Collaborative, the Black Coalition for Safe Motherhood, and Transitions Women Health Consulting LLC. So we're also grateful for our partners, Navigate Maternity, A Light After Nine, the Herd app, and the HAP Impact Fund. But yes, that's all we have. And Rachel, thanks again.
There is one question, Theodora,
Okay,
from there's a question.
I
What
got
mental health resources do you suggest, Rochelle? I'm assuming for mamas perhaps who've had experienced a loss. Do you have any suggestions for um, either doulas to suggest to women who've experienced a maternal loss?
I have a list. The biggest one is PSI, Postpartum Support International. I know our Georgia chapter is phenomenal. I love us here. They're super helpful. And they also have the Georgia Fund where so I'm not completely sure what the other states have, but the Georgia Fund funds maternal health therapy sessions for moms. So
it.
you don't have to pay for them. And there are so many other ones though. There are loss groups. If you reach out to me, I can help you find them. That is one of the big things that we do. There are quite a few. There is also the maternal health hotline. So if there's actually a crisis that you can call that, well, have your moms, I think it was a doula asked, but have your moms call that hotline so they don't feel alone, as well. So we could send that out to Mary, so they can have those resources. Postpartum net, yeah.
That's a good point.
Therapy.
We will share the recording of this workshop with you guys, and we can Birthing the Magic has a resource page, and we do have mental health resources listed on our page under resources. The Margaret, we just answered that question, and then also there's a question under Q&A. How has this changed your advocacy beyond your app? And how telling your story so others know you're so resilient.
Oh, thank you. I have a love-hate relationship. Um, with resilience, the word, because in order for you to be resilient, you have to go through adversity. And as you've seen, I went through a lot of adversity. And then when it was over, then my brain started acting up. But I was already a very compassionate nurse. I always went in. First of all, I was scared when I first started because I started grading in the trauma ICU, and I was like, I just don't want to kill anybody because this is crazy. But I prayed about it, and I was very compassionate. I was like, I'm gonna treat everybody like they're my grandmother, who is my favorite person outside of my child. And but when I went through it as a patient, it was a different lens. I'm like, people aren't seeing me as a patient as a whole. Like when I went through the neurological issue, nobody asked if I was postpartum and had a newborn at home while I can't see every day. Nobody assessed my social determinants of health. Nobody
Mhm.
asked about my mental health or it gave me mental health resources. As you saw, I started talk therapy on my own. Nobody said, you know what, she's a candidate for palliative care, which we
Mhm.
never use in maternal health, which I had a lot of loss, but also I needed like some type of comfort care throughout my pregnancy journey, which was a complicated one, like cancer patients do. You know, I needed that extra support. So it made me think about, it highlighted all the gaps. So now in my practice, I'm like, I see people. I see them. I really do see them.
That's a good point. And then
Yeah.
there's another question of, would you explain hypnotherapy?
Okay. And why were you taking
And
it?
yes, and why were you taking?
Did you see? Did you see the presentation? I needed anything I could get at this point. But so hypnotherapy, like, and it was in a time where everybody was still virtual, but typically you go in the office and they put you into this level of consciousness where you're able to recall certain events and issues, and it's able to kind of essentially like retrain your brain to get over those humps. So she would put like different I forgot what she called them, but like they would plant like seeds in your brain, like if you were trying to stop smoking. That's a big one that they use for hypnotherapy. It will train your brain to say smoking is horrible. We hate smoking. It's disgusting. For my pregnancy journey, I had went through 9 pregnancy losses, all the surgeries, and then I finally was able to get the transabdominal surgery outside of pregnancy, which was the last ditch effort, right? Y'all, I had truly given up. I was about to do that for no reason. So I was like, nah, I have to at least try one more time because this is like the last ditch effort. So I went to hypnotherapy. So anytime I thought about, oh, I'm not doing pregnancy again, it would do something in my mind where I was like, no, we'll try again. Like it's fine.
Mm.
The
That's
brain is
a,
powerful.
I think that would be a good session for Birthing the Magic, to
Mhm.
find someone that could explain what is hypnotherapy and
Yeah.
how
Do
does
a
it.
deep dive.
Yeah,
Yeah.
yeah, I like that. But
Would you say
thank
it was
you.
beneficial, Rachel?
Oh yeah, I'm pregnant. I got a baby because I
Mhm.
had given. When I tell you I had giving up, like after that surgery, it was crazy. I'm like, why did I even do the surgery? I'm not trying pregnancy again. This is crazy. So yeah,
Okay.
100%. It and hypnotherapy isn't like talk therapy where I've been in talk therapy for years. Like you do a few sessions and then you're out. Like if it didn't work after like 2 or 3 for that specific problem, then
Mhm.
it's probably not gonna work. But yeah. Y'all should look it up. It's very interesting.
Got it. And you just sought that out on your own. You didn't have anyone
I talked to the
necessarily.
therapist, I would say my talk therapist, because we was
Mhm.
gonna also do EMDR for the trauma that I've had gone through, but then I kept getting pregnant and they don't recommend that type of therapy. So
Mm.
the hypno was fine, doing the journey. So yeah.
Got it.
You know I'm Googling it.
She's like, I'm watching it on YouTube. Do not go under.
I'm Googling already. I'm already like,
Because yeah,
yeah,
now I'm interested as well. I'm like, wait, hypnotherapy. That was a great question.
Yeah, look it up. Look it up. You never
Mhm.
know.
yeah, interesting. Well, ladies, thank you so much. And everyone, thank you for joining us tonight. I dropped the chat. We will send an email with the link. Did everyone get the link for taking the post session for your CEs, for our nurses, and then doulas, the email to get your certificate? I'll drop it in the chat again. And June, we've got another workshop. Look on our website for that. And we'll send you the information to connect with both Theodora for Navigate Maternity and Rochelle. And the Herd app, which I absolutely love, love, love. Doulas, encourage your mamas. I think it's an amazing tool to stay connected and to keep up with your patients. Yes, we will send a link to the recording, and wonderful. Thank you, Rochelle. Thank you, Theodora. And you guys have a great evening.
You as
Everybody.
well. Thank you.
Talk to you all soon. Bye.